This rather long video is about a sweet little girl that came to the United States from Australia to get tethered cord release surgery. It's really intended for her doctors and family and friends to watch. You're more than welcome to watch it. It's a lot of symptoms. If you feel like you need to go to different doctors in different countries to find out what's wrong with you, this might be a video for you. We're finding what I'm calling a Atlas compartment syndrome, primarily anterior to the atlas, post-traumatic, chronic, putting pressure on the nerves and the arteries and the veins at the cervical cranial junction. Whooshing in both ears after a whiplash.
Yes.
So you have a current working diagnosis. The first thing you think of is, venous compression, that kind of stuff, and they've already done the styloidectomy and a revision on the left side. That's correct?
Correct.
Yeah, you can see the styloidectomy, and they went it pretty good, pretty tight, pretty high. And actually, we're just going to go right to it here. So what we've come to find out is that in some of these cases, slender-necked females, are you able to get this? Do I need to move it closer?
No, we're good.
Okay. So you can see how the jugular vein is being pushed out. There's the transverse process of the atlas. You can see there's something invisible there displacing it. So we have little muscles in there. Those muscles act like dampeners, shock absorbers. Oh, just like your tensor tympani muscle will hold on to the tympanic membrane to buffer it and dampen it from extreme excursions. Well, we also have little muscles in there. So yeah, they might help with motion, but they get injured. Just like if you're around loud music, your ears will start ringing, and that's because the tensor tympani has gotten so overused. It's fatigued. It's not able to dampen like it used to. Well, these muscles in here can happen there too, that way too. So what we've got is a threshold of injury that there are certain scales of thresholds of injury. So if this thing is so loose that a doctor can see that it needs to be fused, it's big enough to catch. If it's not big enough to where it needs to be fused and there's no surgical intervention for it, well, then what happens? Well, you have other clinical symptoms, and especially when you're a slender-necked female, long neck, thin muscles in there, you get injured a little. This is where you get injured. So here we can see, and I can tell you that this is going to be muscle and fascia that is displaced and swollen in there. Yep, there it's there. And we'll go to that in a minute. The obliquus capitis muscle that's holding on for your dear life. Yeah. Right. Okay. So here we are at that slice that I just showed you a moment ago. There's the jugular vein. And I was trying to trace the muscle to find out if it's the one going to the front of the skull, but it looks like it's swollen all around in there. So what would cause that? I bet if you needed to be fused, they would have found that. They would have evaluated you for hypermobility to the point of fusion. But just below that threshold, you can have hypermobility where these muscles are screaming. So it's got to be the fascia that's involved, and there's got to be swelling in there. Now, a compartment syndrome, let's see here. Again, we're talking about a shade of gray here. So a compartment syndrome, you can have acute compartment syndrome, which is it's a dangerous thing. They go in there, they check the pressure on there, they reduce the pressure because there's bleeding in there or some sort of trauma that makes the whole thing swell up, and you can have permanent muscle damage or can mess with blood flow and nerves and things through there. But then you can have compartment, known as exertional compartment syndrome, not a medical emergency. It's most often caused by athletic exertion and is reversible with rest. Well, chronic stuff. This chronic stuff is we'll call it compartment syndrome because that's the closest explanation I have to these muscles being swollen and inflamed. The whole thing darn swollen. If this was an elbow, you'd be very acutely aware that you got a tennis elbow, and you'd put it in a sling sometimes, the real bad ones, or you put a brace on it. That muscle is calcified. I made a video called the cheerleader. Little thing, the cheerleader kept getting thrown up in the air, and the muscle started calcifying all over the place because those again, those muscles are stabilizing and buffering and dampening, she had it going all the way across, like almost the entire little oblique muscle was calcified. Anyway, so we'll show you that in a minute, but yours is, and when we 3D printed it, it showed up beautifully. You can see how it's kind of sticking, it's growing. They're called enthesopathies, calcification of a soft tissue where it attaches to bone. And you've got them on both sides. So before the car accident, you were already dealing with a long neck, a slender neck, and moving that heavy bowling ball through space. So we see a lot of venous congestion here. These are veins dilated. This is an arterial phase. And on the arterial phase, we focus on the arteries and we see some of the veins. And we see so many veins dilated. I mean, one of the thought was, I'm pretty sure they would have tested you for an AV fistula to make sure the connection between the arteries and the veins didn't get blown somewhere and the high pressure artery is inflating the veins. Has anybody checked you for an AV fistula where they went in there with contrast and like to make sure there's...
I've never received any results. Is that way they go through the groin with the camera into your head? Well,
yeah, they're going to check for pressure gradients.
Yeah, I've never received any results.
Right, so a lot of guys around here won't do the styloidectomies. Well, half of them will, half of them won't, without a manometry test, checking for pressure gradients. And one of the things they'll do is they'll find if... Okay, so I've got people, back pressure, and they pop the weakness between the artery and the vein. So the high pressure artery ends up leaking into the vein and inflating the vein. I've got them on the wall. I'll show you where it doesn't look nearly as much as this. You know, you're a slender necked female. We put a lot of contrast through you. So this is not a positive thing. But when I saw that, I'm like, well, I'm assuming I do kind of need somebody to say that she doesn't have an AV fistula driving the whole thing, because once you back up the veins like that, that's one of the things that can happen. That and the dehiscence. So those are two things we need to rule out. Again, I've come to look for anything displacing the jugular vein back in there. And on the right side, it doesn't seem to be too bad. It doesn't seem like there's anything pushing the vein, displacing it. On the left side, there is. You're actually like a poster child for it. Yours is so significant on that side. And what am I saying? That's basically having a whiplash and then not managing it correctly, so that you end up, I'm going to say a compartment syndrome. You're on the spectrum of a compartment syndrome. So that's where it is. Just picture that there's swelling where your head meets your neck and the fascia and everything just got beat up. That was the ground zero for your trauma. When the forces went through you, in front of your atlas. So I, like everybody else, have been seeing this and not knowing what to do with it. So what do? You ignore it. And then you treat the things that you know. And then I had somebody, long story short, I'm showing everything to him, and she says, what about that there? I'm like, I don't know. And she's like, well, I guess it could be, it could be some fascia, it could be scar tissue, it could be something displacing it. It does look... Now, yours kind of does it. Hers was really obvious to where it kind of stood out. Once she drew my attention to it, I'm like, wow, you know what? Everything else is straight in the line, and that thing there's something going on. I wasn't taught that in school, but so I went after it, and sure enough, it changed her life. So these displacements here, now the argument was, well, they were born this way. Okay, if they were born with a loop, then that's a vulnerability to a whiplash that it might be aggravated. Whereas somebody that doesn't have that vulnerability, doesn't have that structure affects function, it's not likely to be displaced by the fascia. But if you act like this is something, and you get in the back of your throat, and you push it from lateral to medial, from medial to lateral, this way, this one on this one, and that one on that one, what's probably going to happen is you're going to get a lot of relief, and it's going to be amazing. And it'll be swollen back there, and like, wow. Now, to get there, somebody has to, there's a gag reflex. It's one of those places that we, as clinicians, avoid. Kind of like doing a rectal exam. There's certain things you just kind of avoid unless you know that you got to go in there and do it. So I've done this on a number of people and found out that is indeed something, and this does change people's lives. And fascia, muscles, scar tissue, adhesions, whatever you want to say, that is not nothing. And I understand that having anybody touch you, you've got to, you know that you don't want anybody to touch you because there's things that they don't know that is not quite understood yet. Well, this has got to be high on that list. So Samuel Clemens says, I was educated once, it took me a long time to get over it. All right, so we're taught things, your doctors are taught things, they want to help you. We all kind of have to struggle. We all struggle with cognitive dissonance and paradigm paralysis. Our successes of our current paradigm kind of lock us into the way we see things, and we almost can't see it a different way. Good thing that little girl, by the way, skinny as a stick, and this is where it was. Showed me to talk me into going after it. And now you can see, of course, look how it displaces, and it's pulled this way, that one's pulled that way. You can see how the jugular vein on the left seems to be unhappy. Is it the posterior belly, the gastric, muscle, soft tissue, fascia, whatever. You've already had one styloidectomy and a revision on that side. So then as we look around there, it does kind of look like it's being, just picture a whiplash. So it looks like it's pushed that direction. And that's probably the posterior belly digastric right there. By the way, these long strap muscles in the neck, they can actually compromise too. So I've had people in your situation where they get massaged, they get their neck massaged, and it really does seem to help because they seem to be aware of every little bit of extravenous drainage. And of course you see the styloid bordering it there. And I'm assuming you're avoiding bringing your chin down. So styloid long, bordering. Again, when I look at this placement here seems to be significant. But to speak to your symptoms, the whooshing, it would be, well, for one, make sure we optimize the venous drainage, which is these chronic compartment syndromes that you have at the cervical cranial junction. Possible dehiscence, likely dehiscence from the back pressure, rule out maybe fistula. I understand how you're not in a hurry to remove the styloid. It would foster a little more hypermobility in there, and if that's what's driving this thing. Have you ever worn a soft foam collar?
No.
No.
Never.
Okay. Well, Occam's razor is a maxim in logic that says the simplest solution is usually the correct one. And the simplest solution on this is that you got swelling, overworked muscles. You've never worn a soft foam collar after a whiplash, which is, but around here we put you in a soft foam collar immediately and let the swelling come out of it, and just treating it like a sprain. So treating it like a sprain that never was managed. Atlas displacing and digging into the jugular on here. We do care about those. Yeah, I was going to ask you some questions about that and what an interesting implant you have. I'm glad it helped. All right, I'm going to make, so you can see how thin the bone is through here.
Yes.
Right, so that would be that's right above your ears there. Now I'm going to bring the density so down to where you're getting flesh. I'll show you flesh. I mean, I'm not going to look from the front because we can see all of your flesh. Yeah, so I can see what T-shirt you're wearing. I've seen it. I can see them. What brand T-shirt you're wearing because it's got its name on it. So even when we bring in the density to where we're getting to soft tissues, the bone is still thin through there. So you're going to end up having a specialist, a dehiscence specialist, sign off. Sometimes it takes a village. You're going to have everything brought back to specs and probably better than you were. You're going to be better than you have been in a long time because they're going to probably go after that. So there's the thinness in through there.
What would a specialist like that do?
Well, they could put a little piece of Teflon in there. Okay, now, I'm only a chiropractor, and in some countries, just tell them I'm a patient advocate.
Yes.
Don't trigger them. No need. You hired a patient advocate to look at your stuff.
Yes.
Right.
Yeah. Or there they call them a chiropractor. Here we call them patient advocates. Whatever you want to do. Don't trigger anybody. Okay, so what they do, it's above my pay grade.
Yes.
A skull-based or a neurosurgeon even. but it's
Yeah.
skull-based ENT. Talk about specialty within a specialty. 1,000 ENTs, I bet you none of them want to go do the, I mean, how many of them would want to do the hardest, most difficult thing? Brain surgeon, it's more of a brain surgeon. Right, so the neurosurgeon that saves people's lives by going inside, opening up the skull, or the guy who would do a trigeminal neuralgia surgery, the guy who would put a piece of Teflon between an artery and the trigeminal nerve. I mean, that's the way, I think it's probably going to be a final exam for the best neurosurgeons out there. The people that do that had it probably done to them and somebody saved them. And they know how hard it was to find somebody to save them, so that's what they do for a living. That's how this stuff works.
Yeah.
It's kind of like why I do what I do. I work this hard to save my wife. Yeah, you could have lived your whole life and not known you were thin through there till you put a little back pressure in there, pop an AV fistula, pop your dehiscence. Yeah, I had to put an arrow on that mastoidectomy. Okay, yeah, so we've got a couple different shots of this placement through there. And what you do, experimentation beats theory all day long. You find a bunch of stuff on imaging, you play with this, you play with that, you're like, oh, this is causing that, that's causing that. So when you go in after that, is that going to help your whooshing? I would like it to, but I think you're going to like it. We need the swelling to come out of this. We need you to wear a soft foam collar. I understand not wanting the Atlas to be even vibrated with a percussion machine. I get it, especially since this thing is so swollen and so inflamed. It's almost like you're better to wear a collar for a couple of weeks, let the swelling come out of this thing, and actually that would be the next step. Somebody who does Rolfing. So anybody who studied Ida Rolf's work and you show them these images, they would probably be willing to go in the back of your throat and try to move some of that around. Anybody who does fascia work, the fascia people know they've changed people's lives, and then the whole thing is going to be boggy and swollen because it's a little loose in there. Okay, now we removed some of the structures in here, and we can see the first rib on the right is dropped down. Have you been getting any prolotherapy or anything to tighten up loose stuff?
No.
Okay, well, if you're around here, we'd have somebody put prolo in there and that ligamentous attachment there. You know what? Let's show that to you.
So I had the same thing. I'm wondering if that's not tethered cord related with all the tension pulling downward.
Right, so the reason we care about this is the scalene muscles attached to that. The scalenes are, if they're not modulating correctly, you'll have a little bit of a bobblehead, or you're not exactly the most stable structure when you go through a whiplash. These are vulnerabilities we all kind of have, and then, so this one also is not exactly touching, it's kind of free, and it's dropped down a little bit. You can see the facet where it used to be attached. I don't know what the Lord's going to say to you, but the devil's going to have you say wear a heavy backpack to push these ribs down even more. Now, I've shown this to different doctors, and I like this one thing this one guy said, and it wasn't on this. It was one real bad. I'll show you one that's really. I wanted a surgeon to reattach it. Nobody wants to do surgery on it, and then the prolo to tighten it up. If you just get them to where they move less, that's what the doctor said. He's like, I know it looks scary. Yours doesn't look so scary, by the way. I'm putting you on the lift, and I'm showing you everything. This is not a scary looking one, okay?
Okay.
So scary is free floating down, and we got to do something about it. It's driving the whole neck to be crooked. The whole neck goes crooked from them. Oh yeah, your neck's not crooked. No, these people, it's bad. Anyway, he's like, if I can just get it to where it doesn't move as much, you'd be surprised how the body can adapt to it. Even then, when they look real scary, just less motion because this is where the scalenes anchor, and it's trying to, stabilize and hold your head up. Anyway, I think a little prolo in there would go a long way, and this ligamentous attachment in there. Okay, so we've kind of documented that. Your spine is pretty straight. It's not ridiculous. You got some corkscrewing in through here with these soft tissues that look like they're just pulled in a bunch of different directions. Look at that. That's the left side.
Are those veins or arteries?
This is artery, this is vein.
Okay.
This is where she's already had 2 resections in there.
Okay.
And I think she moves too much up in here. All this is just sprayed and loose up on top. And we'll show you some stuff there. Yeah, different angle here. And this will all be on your thumb drive. All right. So this is a line through the bottom through the center of your frame and magnum. We're looking at the bottom of your skull. This is the left side.
Yep.
Okay. You got your orientation. You're good. And then we put the atlas. Put the atlas on it. And there's your atlas. So I'm a guy that has changed people's lives and been a hero because we found a misaligned atlas and put it in place. And here's an interesting thing. So your atlas looks pretty in the center, pretty not too far off. Looks rotated. There's a little rotation there, anterior on the left. The joint surface here is larger on the right side than the left side, which tells me long-standing asymmetry. You're loading more along this this pillar, this kinetic pillar. But it only matters to a guy who wants to come along and adjust an atlas. So when we see, that's what was important to me. Yes, your jugulars, we care about the jugulars there. These calcifications, look at that. That's those enthesopathies of those.
So the atlas is technically out of alignment?
Oh, the atlas is anterior on the left.
Yep.
And we're about to go there. All right, left head rotation. The atlas goes up to the right. We 3D printed this particular orientation, and I'll show you why in a minute. There's lots of good parts. You got lots of good parts. The expensive injuries you don't seem to have, so that's good. I've seen these where the skull will rock over, and the skull will make contact with this odontoid process. Yeah,
wow.
Or the atlas will. This thing will touch there, and then when they turn the other way, it slides back and forth. So this is like a back and forth, and I don't even know if anyway, so I did show this one here. I don't know that I captured it on the right side because it was okay, but we'll make sure I got that you got everything. Right. Left head rotation. So with left head rotation, the atlas goes to the right. That's just what happens. It's normal. So it does move quite a bit up to the right with left head rotation. Okay. Again, we're seeing all this soft tissue that's come displacing forward. I mean, look how it goes this way and then comes back towards the atlas. I just see all kinds of swollen, watery injury up there. Left head rotation. Actually, you probably got a little bit on both sides. With left and right head rotation, does it change any of your symptoms?
Not really, but I notice if I've got my head to the right for a while, I tend to feel really dizzy.
Okay. Well, one of the things we look at is we care about the vertebral artery being pulled tight, and you can't say that it's a symptom causing a problem or anything, but we look at it.
So it's turning to the left, right?
This is left head rotation. The atlas tilts up to the right. So here we're looking at the atlas making contact with C2. The textbook says that you need to maintain 20% contact, so 80% of it can slide off. Let's do a better job. So you're clearly maintaining 20%, easily 20% contact, so your atlas is not sliding off of C2 too much.
Oh, that's good.
Right, on that side. Now, on the other side, the way your C2 is shaped, and it's not just you, a lot of people are this way. So what's stopping? See how it's flat through there?
Yes.
Right. So textbooks, we have to have a textbook say something that's normal and something that's not normal. When is it causing symptoms? When is it not? Normal chemistry, normal motion. But it's not cookie cutter like that. It's individual to the person. So textbooks are a good guide, but they're not written in stone. You have to have a mechanic sensibility. You have to have you actually have to have the Holy Spirit. The Lord will show you. Go after that. That is something. So just looking at how your C2 is shaped, Atlas can have a tendency to slide. There's like nothing stopping it there except joint capsule, soft tissues, ligament structures. That's what we got. So that, it's not a stretch to think that this is where you're prone to have an injury. This is a vulnerability. This is where somebody gets injured. So just picture left and right head rotation, going a little too far to the left, and I got some more screenshots to show you that. But basically, I don't want you to turn your head. Actually, I don't want you to turn your head to the left or the right, but definitely not to the left. I'm saying that the soft tissue, the ligamentous stop is, again, like that tennis elbow. Somebody's playing tennis so much, it gets swollen, it's compromised. You, my friend, so there's this guy, Kevin, I tell everybody about. This guy,
Yeah.
amazing. He went and had all these procedures done. This is exactly how I talk about you, by the way. Went and had a whole bunch of procedures done, went everywhere. Everybody keeps, he's a little better, It takes a village, everybody's done their procedures, like this is, and he's like, I'm not gonna stop, I'm gonna keep until I'm perfect. And so he came here because it's one of the stops, and one of the things was, he has this thing where whenever he would go from lying down to upright, or upright to lying down, he felt like his brain got punched. And then in the physical exam, we found that when he jutted his jaw forward, put a little extra tension in there, and when he did that, he was able to do that motion, lying down to upright, and his brain didn't get punched. So then the rationale is, okay, now you can go back to your Regenerex and get all that stuff there, ligament structure, let it put the glue in. And you hold your jaw forward for 6 weeks. When you do this motion, stop the derangement, then the glue will set up and you'll heal. So it's not everything can be shown up on a DMX, the digital motion X-ray. So there are, we do MRI flexions, extensions. There are things that we check for, and we should, but it's not everything. So what I'm saying is that there's going to be a motion in there that's difficult. You can't prove it, maybe, except the experimentation would prove it. You stop moving this thing, let the swelling come out of this thing, wear a collar. You've got people who are going to say if you wear a collar too long, your muscles are going to get weak. Okay, well, some sprains are so bad it would have been better if you broke the neck, And I know somebody with a broken neck, she had to wear a collar for 3 months. There are physical therapists that work with the doctors that fuse things, and one of the things is you wear a collar, and you'll do exercises wearing the collar. So we're not. There's a collar to where it takes the weight of the head off the neck, which I kind of think we need to let this thing heal. Now, whenever the Lord tells you something, you're always going to have the devil that says, you can't do that because of this. But you got to be able to hear, nope, I need this thing to heal up. And if I listen to you, you'll never let it heal. You'll never let me wear a collar. You'll never, because you'll say the muscles are going to get weak, Well, how about there's a time and place for everything. So there's a collar that takes the weight of the head off, and then there's a collar that doesn't support the head and just keeps you from moving your neck. Heck, a scarf around your neck would keep you from moving your neck, just a reminding of a scarf. There's a motion in here, an excessive motion, and this is where it's going to be, and we'll show you something else. And I've got proof of it here.
Are you thinking wearing a collar 24/7?
I got people that only need to wear a collar when they sleep, because that's when they screw it up. So I lay it out there, you prayerfully consider what to do, and you're like, all right, I'm going to run this experiment and that experiment. You run enough experiments, you'll have this whole thing figured out. No, it wasn't that, it was this. Okay, I didn't know you had to learn. It took 3 experiments to find out what was, and you only had to wear the collar at night. You didn't have to wear it during the day. Left head rotation, the atlas drifts further forward on the left. So that's your vulnerability. There's an anterior slippage. It slides too far forward on the left. And as a guy that does what I do, I would come really far forward on the left to bring that back. Now, here's another little piece of thing. 35 years I've been adjusting these atlases, and I find that the neck is crooked as a dog's hind leg. You adjust the atlas, it straightens right up. All kinds of cool stuff. So we do before and after x-rays all the time. What did I do? I got the muscles in here to relax. and the toilet flushes, and they feel amazing, they feel lighter, because these muscles that have been engaging and locking down. So we send like a little shock wave, a percussion energy wave, a vibration through there, and we're wanting to move the bone to the correct direction. That's a good rationale. But what we're finding is that the muscles have been guarding and splinting in a spastic state, and we're getting the muscle to release. So, right, there's this one right here, this guy right here. That calcification of a muscle is just holding on for dear life. Bless your precious little heart. Yeah, this is your parting gift. You're going to leave with this, and you'll have an understanding of what's happening mechanically to you. Okay. Yeah, you got it on both sides, but that's the one. Again, left head rotation, different angles. Right head rotation. Yeah, I couldn't get past all this soft tissue in there.
Was the atlas hitting the IJV right there in that last one?
Yes. Right head rotation, the atlas slides up to the left.
There's soft tissue involvement, and she has instability there. That's what's causing the shifting.
Right. So for me, it's the hypermobility. I don't want to call it instability. I'm like hypermobility, like a sprained ankle. You know, you put it in a boot, stop moving, sit up, stand up straight. You know, take the weight, load it correctly. Right. Let the swelling come out of it in a few days. You know, probably might even take 10 days for the swelling to come out of it. There are guys who shaved the transverse process of atlas, so nobody shaved your atlas down.
They did on the left.
They did on the left. They shaved it down a little bit on the left. Right head rotation. Also a very good view of the tension. So that muscle is under tension. You're left on top, right on bottom. Now, one of the things I look at is I want to see if somebody, really comes off their axis. And your C2, the top of your C2 seems to be, the green line is the foramen magnum. So it seems to be pretty symmetrical there. Is the atlas going further to the left with right head rotation? Yeah, I think so. It seems to move a little bit more. But either way, the atlas seems to drift forward on the left and right head. Left, neutral, and right head rotation, the atlas seems to drift too far forward. And the muscles are going to be engaged, and there's going to be some swelling in there. And that's how I would adjust you from that to fix that anteriority. From these views, now we don't have weight-bearing x-rays. The typical protocols, we add weight-bearing x-rays to this. But I'm going to say it's that anterior slippage that we need to avoid, and that's how we would adjust you. There we go, thank you. The obliquus superior capitis muscle. You have an enthesopathy of the obliquus superior capitis muscle on both sides, meaning that this thing is holding on for dear life. So if there's one thing that causes an injury, there's something else that keeps it from healing. You keep walking on that sprained ankle, it'll never heal. You walk on that broken toe, it'll never heal. You need to see it, understand it, it's demystified to you.
So how does that rectify? By wearing a soft collar?
Rectify. Well, how about improve? Rectify
Okay.
means complete correction.
Yeah.
How about we stop doing things we ought not do? I had a waiting room filled with people, and there was only one patient, and they were all, the whole family, because the person was dying, and they came from the islands. And long story short, I'm like, Lord, what am I supposed to do? He told me what to say. I went into the waiting room. I said to her, is there anything you do that people tell you can't do that, you're going to get sick? And she says, no. Now the brother stood up and was like, oh yeah, I know, I've been telling her this thing her whole life. So whatever he told me, I knew that's what it was. And of course it was, that's what it was. Okay, but to rectify, that's not what your question was. The question was, how do we improve that? Correct posture, wear the collar. I've said to people, do you feel like you're going to be healed? And it's important for them to, yeah, I'm going to find my solution. I'm going to be okay. All right, then walk around like that. Walk around like you're going to be fine, and that God is good, and God can be trusted, and He loves you, and there's a solution, and He's going to lead you through this thing. So walk around here hopeful and knowing. There's a verse in the Bible that said, where would I be if I did not believe I'd see the goodness of God in the land of the living? We got to believe that we're going to see the goodness of God, and we walk around a certain way, we smile.
Could forward head posture, looking down at a phone, put tension on that muscle right there?
Yeah, oh yeah, if you're like play Sudoku or whatever it is, I mean, if you're a Candy Crush person, and right, so I came down to, yeah, this is a trauma, but it's a repetitive injury that's keeping you from healing and causing swelling. And you're nursing a compartment syndrome of some kind in there. And there's another shot of it actually. Same muscle, different look, different shot. Yep.
So
Hopefully
that's the left side and the other one was the right side.
Yeah, I figured I'd show a different orientation there.
Is hers problematic on both sides?
Yeah, it is. It is.
That's right, because you showed me it was.
Yeah, it's on both sides.
Yep.
You know what? I think one of them. Let's go back to. Here we go. I got a great shot of it. So it does look like it's more on the left, doesn't it? Like it's bigger, longer. Yeah, the one on the left is bigger and longer.
Okay.
It does. Yes.
Right. So it is not a perfectly symmetrical thing. Yeah. Larger, smaller.
Okay. That attaches the atlas to the base of the skull.
Yeah. There it is. Helps stabilize. Buffer.
Okay.
Dampen. Yeah, and I think when I've been adjusting people for 35 years, I think what I'm doing is getting that muscle to release. Right, these are the different shots. I was trying to trace a muscle from the base of the skull, from the front, to see if I can get it going to the transverse process. I wanted to see if I could catch what was displacing it. And now an MRI would be a better shot, slice by slice, to be able to trace a muscle fiber. So the best I came up with was the compartment because it seems to be swollen. Yeah, the prevertebral fascia. Yeah, this is how I went down that rabbit hole. Compartment syndrome, list of clinical correlates to that fascia, because I couldn't find fibers. I wanted fibers, muscle fibers. So I pivoted. Chronic compartment syndrome from an athletic exertion. And you haven't been able to rest it because you haven't worn a collar. That's the story as I see it. Anything you want me to look at particular?
Is her pineal gland
Calcified as hell. Yeah.
Is that it right
I
there?
thought I saw it before.
Yeah. Oh my gosh! I printed it. It's in the garbage can. If you want, I accidentally, I have a 3D print of your calcified pineal gland. It's in there.
That'd be great.
Would you like to see it? Okay. Yeah. It's in. I can pull it out. I can visit it.
And there was one.
Yeah, so I saw it earlier.
slide.
Is there a reason that those? I know that they calcify generally just when we get older, but is
You talking about this?
No, the pineal gland, whenever it calcifies, is that spinal problems that tend to cause that you've seen, or is it
Okay.
just?
So I don't know what it is. I know a lot of people talk about it like it's this or it's that.
Mhm.
You know, when you're a hammer, everything looks like a nail. So for me, everything is turbulent cerebrospinal fluid. I've seen calcified. I've seen other things, not the pineal gland, but I've seen other things calcified in the cranial vault. And it's, you know, you look it up. What is that? Well, it's from traumas, head traumas, bleeds that stabilized, and it doesn't mean anything. So, all right. So, some sort of physical, mechanical trauma, but that's everything I have in my mind. It could be other mechanisms, but. Oh, actually, so the other thing, when I was talking about slouching and how I walk around scurrying, it's because I'm seeing calcifications of these ligaments here, which means chronic slouching. The ligament here will calcify, and these spinous processes will get a little pointy down in here. Not seeing it. So actually this thing is calcified, so I don't know that the discs are gone there. So I don't know how straight you can actually be at this point. So let's just say I said, quit slouching, you know, like I don't know that you can. Actually, it's so funny. We had a doctor that is very famous in this field, and we did the scan on him, and he looked like this too. So he talks about posture all day long. He talks about having your monitors up and having everything up, and he's not wrong. But he's I mean, and that's going to happen to me too. So you know what? Anyway, so it's calcified. I don't think you can go straight at this point.
Wow.
So.
It's almost like a natural fusion, huh?
Yeah, yeah. Yep, there it is. All right. Any more questions before I go find that calcified pineal gland?
I see it. You see it?
Yeah, yeah.